Hello everybody, we'll talk about the last part of the respiratory system, and in this part first we'll talk about the alveoli and its wall, and then we'll talk about the blood supply to the lungs. Then we'll talk about the mechanisms of breathing or respiration. Then we'll talk about a fluid called the surfactant, which is very important to keep the alveoli open. We'll talk about the respiratory volumes and capacities. We measure the respiratory volumes and capacities to measure the lung function test. Lung function. So these two measurements are called the lung function tests. Okay. So how much your lungs can expand and recoil or contract, that we see by these volumes and capacities. Then we'll talk about the partial pressure of gases, the partial pressure of the oxygen and the partial pressure of the carbon dioxide. So these are the two gases we uh, gases are exchanged and transported. So one thing is very important. The gas moves from one compartment to another or one place to another by the pressure. So the difference of pressure. Gas always moves from the high pressure to the low pressure. Okay. So we'll see the pressure at different locations and how the pressure difference moves the gas from one place to another in the lung and in the tissue. Okay. So another thing we'll talk about is the transport of gases. You know that blood transports the gases. You already know that. How the blood transports oxygen and carbon dioxide. We'll see that. Then we'll talk about the regulation of breathing. You know, the breathing changes the rate of respiration, right? When you do exercise or when you are, stressed, the breathing pattern changes. So we'll see what regulates the rate and depth of breathing. So here you see uh, the alveolar sac and the alveoli inside the alveolar sac. So one thing you see here, how beautifully each alveolus gets capillary bed on it. So each alveolus, if this is the alveolus, gets a capillary on it. The capillary bed wraps the alveolus, and each alveolus gets a capillary bed on it. So this is the capillary, and this is the alveolar wall. Alveolar wall. Okay. And we know that if it is inside the lung, right, we know that blood goes to the lung to get the oxygen, right? So inside the capillary you have the blood that will get oxygen from the alveolus, and always carbon dioxide moves to opposite direction. So carbon dioxide moves from the capillary blood into the alveolus, and that is the gas exchange in the lung. Okay, and to make sure that each alveolus is participating in that gas exchange, each alveolus gets a capillary bed on it. You can see here in this picture, right? So how beautifully uh, the inside the lung these microscopic structures are. Okay, now the wall of an alveolus has three types of cells. You see these cells, these are simple squamous cells. You know, simple squamous, flat, right? A single layer of flat cells. So these are simple squamous cells. Okay, uh, and most of the cells, the wall is mainly formed by a simple squamous. So it is like this. You know, the flat squamous cells you already know. So this is the wall of the alveolus. Okay, nucleus inside the squamous cell. It's a single layer of squamous. Uh, Also, in between the simple squamous, we see other two types of cells. One is called surfactant secreting cells or type 2 cells, and another type of cells are called the macrophages. So this is a macrophage. Okay, and simple squamous again. Okay, so this is the wall of an alveolus. So simple squamous cell, that is mainly forming the wall, right? Squamous. And simple squamous cells are also called type 1 cells. Okay, and these are surfactant secreting cells. Surfactant secreting cells. That means what? These cells secrete surfactant, a fluid. I mentioned before, a thin layer of fluid is present in the inner surface of the alveolar wall, like this, a thin layer. However, that thin layer of fluid, surfactant, keeps the alveolus open. If that surfactant is absent, then what will happen? The alveolus will collapse. So surfactant is a fluid secreted from the surfactant secreting cells, and that forms a layer in the inner surface of the alveolus to keep the alveolus open. If the surfactant is absent, then the alveolus will collapse, and that happens in infants due to lack of surfactant secreting cells in the wall of the alveolus. It is a genetic disorder mainly. If that happens, then in the alveolar wall inner surface, that infant doesn't get the surfactant, so the lung collapses, and that is called infant respiratory distress syndrome. Or Okay, so that surfactant secreting cell is very important, right? And these cells are also called type 2 cells. Type 2. So type 1 cells are simply squamous and type 2 cells are surfactant secreting cells. And macrophages, phagocytic cells. The presence of macrophage is helpful here because the air you inhale that goes to the lung, and that air might have microorganisms, right? That macrophage present in the wall of each alveolus would help to destroy those antigens. So those are three types of cells in the wall of the alveolus. Okay. Now, if the wall of the alveoli is destroyed, that is a clinical condition. Destruction of the wall of the alveolus uh, of alveolar wall, that is called alveolar wall, that is a clinical condition that is called emphysema. Okay, so the total surface area of the alveoli would be less than normal person. So gas exchange will be less. So the person will suffer from shortness of breathing, right, and other complications. So less gas exchange will occur because of the destruction of the alveolar wall. Uh, Another clinical condition in which the alveoli get infected and secrete, the alveolar wall secretes fluid inside the alveolus, and that is called pneumonia. Okay, so the alveolar wall or lung tissue gets infected by virus or bacteria. Sometimes it can also occur due to chemicals. Some chemicals that can cause the inflammation in the alveolar wall. So inflammation can occur due to infection, microorganisms, or by the chemicals. And in that case, the alveolar wall will secrete fluid that will accumulate inside the alveoli, right? That fluid sometimes becomes pus. So that is pneumonia, and the person will have uh, very shortness of breathing or difficulty of inhaling the air because the alveoli are filled with fluid or pus. Uh, so those are two clinical conditions. Emphysema and pneumonia are directly related to the alveoli. Okay, blood supply to the lungs. Your lung gets blood from the heart, right? Heart sends the blood into the lung through the pulmonary artery. So this is the pulmonary artery. Pulmonary artery, you all know, takes deoxygenated blood. That means carbon dioxide rich blood goes to the lung to get the oxygen. So that is one type of circulation in the lung. Heart sends carbon dioxide rich blood to the lung, and blood gets the oxygen from the lung and goes back to the heart by the pulmonary veins. Make sense? So this is pulmonary artery, brings carbon dioxide rich blood into the lung, right? And blood gets oxygen, and oxygenated blood through the vein, pulmonary vein, goes back to the heart. Okay, this is oxygen rich blood. So this circulation is called pulmonary circulation. You already know about this pulmonary circulation. However, lung tissue itself needs oxygen, right? Who will give oxygen to the lung tissue, to the alveoli of the lung? Because tissue needs oxygen and nutrition, right? So that is given by the bronchial arteries. So bronchial arteries take the oxygen and nutrition to the lung. So bronchial arteries. Okay, makes sense. So you see, pulmonary arteries bringing the blood into the lung for gas exchange, and bronchial arteries bringing the blood into the lung to give oxygen and nutrition to the lung tissue. And bronchial arteries uh, are systemic, part of systemic circulation. You know, in systemic circulation, blood goes to the body, right? To all the organs to provide oxygen and nutrition. So pulmonary and systemic, both circulations are present in the lung. And the area here where the lung, the blood vessels pass through, that area in the lung is called the hilum. So hilum is the area through which the blood vessels, that means arteries and vein, pass through. And also you remember the primary bronchus enters into the lung, right? Right and left through the hilum. So this is the hilum, primary bronchus, as well as the blood vessels pass through. That is the hilum. Okay, so that is the blood supply. Pulmonary bronchial arteries take the blood to the lung, or brings the blood into the lung for to give oxygen and nutrition, and bronchial vein returns the deoxygenated blood. Okay, return the deoxygenated blood to the heart. Mechanism of breathing. Now, breathing or respiration or pulmonary ventilation, same thing, has two phases: inspiration or inhalation, expiration or exhalation. Okay, inspiration is the process by which the air from outside of the body enters into the lungs, and expiration is just opposite, the process by which the air gets out from the lung to the atmosphere, to the outside of the body. Now, to understand the mechanism of breathing, you need to understand the pressures in different compartments. So let's talk about the pressures first before we talk about the inhalation and exhalation. So this is the lung, and inside the lung the pressure is called intrapulmonary pressure. Intrapulmonary. Makes sense. Intra means inside, pulmonary means lung. Pressure also called intra-alveolar because the lung is filled with alveoli. Okay, intrapulmonary or intra-alveolar pressure. So this is one you need to know. Remember, this pressure is not fixed. This is very important. It's not fixed. It changes. Okay, it changes. Then outside of the body, atmosphere. At sea level, atmospheric pressure is fixed, which is 760 millimeter of mercury. This is the unit. Okay, so at the sea level, the atmospheric pressure, that means the pressure in the air outside of the body, is 760 millimeter of mercury, and this one is fixed, not changing. Okay, and you remember the pleural space. I talked about that. The pleura is the covering of the lung, which has two layers, right? And the space between the parietal and visceral, this is called intrapleural space. So the pressure there is in the pleural space, the pressure is intrapleural pressure. So very simple, right? So three pressures you need to know. Intrapulmonary inside the lung, which is also called intraalveolar, which is not fixed, it changes. Atmospheric pressure 760 fixed outside of the body, and in the pleural space the pressure is intrapleural pressure, which is also fixed. So this pressure is 756 millimeter of mercury. Okay. Now intrapulmonary pressure, I said it changes. Pressure, it changes between 759 to 761 millimeter of mercury. So only 2 millimeter difference, right? 759 to 761 millimeter of mercury. Okay. Now I told you at the beginning that gas moves from high pressure to low pressure. Make sense? So now let's see if the interpleural pressure is at the lower end 759, then here 759, outside is 760, right? So due to that 1 millimeter of mercury pressure difference, the air will get into the lung. Makes sense? And that 1 millimeter of mercury difference is strong enough to move the air from outside of the body to inside, and that is called what? Inspiration. Okay. And when the pressure inside the lung is 761, now let's talk about the higher end, 761. Now you see here is 761, outside is 760, so 1 millimeter pressure high inside the lung. Okay, so the air will move outwards this way because of the higher pressure inside the lung, and that is called what? Expiration. So that pressure difference moves the air from outside to inside or inside to outside. Okay, now we'll talk why inside the lung the pressure changes, intrapulmonary pressure changes. We'll talk about that soon. Okay, Now let's talk about the intrapleural pressure. Always 756. That means here always 756, right? Even when inside the lung the pressure is 759, this pressure is intrapleural pressure is less. How much? 3 millimeter of mercury. And when inside the lung is 761, here how much less? 5 millimeter of mercury. So intrapleural pressure is always less than intrapulmonary pressure. How much? 3 to 5 millimeter less. That is minus 3 to minus 5, right? And why always intrapleural pressure is negative or less than inside the lung? This pressure is very important to keep the lung expanded in some extent, so it will not collapse. Because if the pressure is less inside than outside, then what will happen? The lung will not be able to expand, will collapse. Make sense? So around the lung the pressure is low, so the lung can expand and stay expanded. That is very important. Now there is a clinical condition, like this is your chest wall. Okay, you think that this is your chest wall. Okay, wall of the chest, and if something pierces through the chest wall like a knife, passes through the chest wall and also pierces the parietal pleura, then what will happen? Outside of the body you see the pressure is 760 millimeter of mercury, right? And interpleural pressure is 756, you know that. So the air will suddenly move from outside to inside because of that 4 millimeter of mercury pressure. So quickly the air will enter around the lung and fill the space. The pleural space will get filled heavily with the lung. So the lung will collapse, will not be remaining in expanded because of the higher pressure around the lung. Okay, because now it is 760 outside and 759 inside. And that condition, the collapse of the lung due to the injury in the chest wall and increased interpleural pressure is called pneumothorax. Okay, so if you take the x-ray, the picture, this is the trachea, bronchus, and this is the healthy side, the lung, and this side you'll see like this. In x-ray you can see that the lung has collapsed. Okay, so that is pneumothorax. Okay, so now you know those are the pressures, three pressures you need to know, and the pressure difference moves the air from inside to outside and outside to inside. So here you can see those that I just showed you in drawing. Now I told you who changes the pressure. Why inside the lung the pressure is not fixed, the pressure is changing. 759 to 761, we'll see that. Okay, you must remember that lung is sitting on the diaphragm. So this is the muscle called diaphragm. Okay, and the base of the lung is strongly attached to the diaphragm by fibrous tissue. Okay, and this is the chest wall here. So these are the ribs and intercostal muscles in between the ribs. Costal means ribs and intercostal means in between the ribs. So intercostal muscles. Okay, and now you already know that the parietal pleura is the outer one, right? And the visceral pleura is the inner one, the covering of the lung, right? So this is the visceral pleura, and then this is the parietal pleura attached to the chest wall. So this is the parietal. Okay, now what happens when we inspire the air? Before the air gets in, a signal goes to the diaphragm by the phrenic nerve. Phrenic nerve. This nerve brings the signal here to the in the diaphragm, and diaphragm contracts. So remember, this is very important. When diaphragm contracts, it moves downwards, moves down. So the diaphragm will move downwards. Okay, and that will do what? You see, the bottom of the lung is strongly attached to the diaphragm by the fibrous tissue, so it will pull the bottom of the lung downwards. So the lung will expand this way because the lung is highly elastic, right? So if you pull the bottom of the lung, then the lung will get bigger this way, vertically. Okay, so vertical expansion will occur. That is one. And at the same time, intercostal muscles. Okay, external intercostal muscles will contract. Okay, so when the intercostal muscles contract, then what will happen? The ribs will move forward. Okay, so the intercostal muscle will uh, uh, contract, and that will move the ribs forward and slightly upwards. Elevation of the ribs. Okay, so that is the external intercostal. There are two sets of intercostal, external and internal. So we are talking about the external. Okay, so now you see, due to contraction of the diaphragm, the lung will expand vertically, and due to contraction of the external intercostal muscles, since the ribs will move forward, the lung will be pulled forward because the pleura is attached to the chest wall. So when the chest wall will move that way, it will also pull the lung that way. So the lung will expand this way, horizontally or transversely, okay, anterior posteriorly. So this is the front, anterior, this is the back. Okay, so the lung will expand. So due to the contraction of diaphragm and the external intercostal, the lung will, the result is the lung will expand. And when the lung will expand, the pressure inside the lung will go down to 759 millimeter of mercury. Makes sense? Because same amount of air inside the lung, but you are expanding now, so the pressure will of air will go down, and outside it's 760. Remember I talked about that. So due to that 1 millimeter pressure difference, the air will get in, and that is the mechanism of inspiration. Okay, due to the contraction of diaphragm and external intercostal. Okay. Now, uh, when the diaphragm will relax, then it will move up again, right? So when the diaphragm will relax, then what will happen? The lung, the diaphragm will move up. Okay, and now you see that when the diaphragm will move up, since lung is highly elastic and you expanded it before, right, uh, by pressure. Now the pressure is gone, so the lung will recoil by itself due to the elastic property. So the diaphragm will relax, will move up, intercostal muscles will relax, go back. Okay, so the lung will recoil, and when the lung will recoil, the pressure will go up to 761 because you are squeezing, so the pressure inside will go up. So that will expel the air out. Okay, and that is the expiration. So uh, two muscles are very important, right? The diaphragm and external intercostal for the normal breathing or inspiration or expiration. Okay. Now for forceful breathing, some additional muscles are used in the body, including the abdominal muscles. Okay. Now here you see the same thing that I explained, right? So the intercostal muscle and diaphragm here, intercostal muscles here. Surfactant, we already talked about that, a fluid that lines the inner uh, surface of the wall of the alveoli and keep the alveoli open. And if someone has lack of surfactant secreting cells, then the surfactant will uh, uh, be less, and that may cause the collapse of the alveoli. It happens in infants more due to lack of surfactant secreting cells, usually due to genetic disorder. But if premature baby is born, that baby might have uh, lack of mature surfactant secreting cells, so that can also cause infant respiratory distress syndrome. So genetic, that is difficult to uh, fix because the infant will not get the surfactant secreting cells. But if the lack of surfactant secreting cells due to premature birth, in that case, if you take care of that infant, then the cells will get matured and start to secrete surfactant. Respiratory volumes and capacities are to test the lung function. There are four volumes: tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. Okay, so we'll talk about those. Then there are four capacities. So four volumes and four capacities. Capacities are inspiratory capacity or IC, functional residual capacity, vital capacity, and total lung capacity. We get the capacities by adding two or more volumes. So we have four volumes, remember. By adding two or more, we get these four different capacities of the lung. Okay, so first, what are those volumes? Tidal volume, very simple: how much air you inhale or exhale in normal breathing. Okay, so the amount of air you inhale or exhale in normal quiet resting condition. Okay, and it is same amount of air you inhale and exhale, uh, 500 milliliter, okay, half a liter, and that is same in male and female. So if I draw the lung here, so this is the lung, okay, and in normal inspiration and expiration, you inhale or exhale 500 milliliter of blood. That is the tidal volume. Okay, so let's say this is 500 milliliter. That is tidal. Okay, then if I ask you to take normal amount like 500 milliliter inside your lung, okay, so that is the normal amount you have taken. And now if I ask you to stop and take more air forcefully, take more air forcefully. So after you take normal amount, you can take a lot more by forceful inspiration, right? So this extra volume that you can take, normally we don't, but if you forcefully, as much as you can take, that is the extra volume, is called inspiratory reserve volume. Inspiratory reserve volume is the extra or additional volume of air that you can forcefully inspire, okay, or take into the lung beyond the normal amount. So normal is this red one, which is tidal volume, 500 milliliter, right? And now the extra amount you take forcefully, that is inspiratory reserve volume. This is about 3100 milliliter in adult male and 1900 milliliter in adult female. Why in male that forceful amount is more, inspiratory amount is more? Because the strength of the muscles, respiratory muscles, okay, and the size of the lung. Uh, now let's think about expiration. You expire normal amount of air, 500 milliliter, right? After that, if I ask you to expire more, you can expire more, right? So this is again 500 milliliter you have expired normally, and now if I ask you, okay, take expire more forcefully, you can do that. This is the forceful amount, additional amount that you can forcefully expire. That is called the expiratory reserve volume. Okay, so the reserve volume is the amount we don't use normally, but when we need, we can use. That's why it is called reserve. Now when you use inspiratory reserve volume, if I ask you to uh, go underwater and try to stay there as long as you can, then what you will do, you will take as much air, right, as much you can take inside the lung. So that is one condition when we use that reserve volume, right, inspiratory reserve volume. um, Another is during exercise, we always take more air, right, more than normal. So expiratory reserve volume, the good example would be if I ask you to blow a balloon, you will try to push as much as water air you can, right, from the lung to expand it. That is uh, the use of reserve volume, expiratory reserve volume. uh, so those are the reserve volumes. Then residual volume. Residual is the amount of air that remains in the lung after forceful expiration. If I ask you to expel all the air out from your lung, you do that. Still, some air will remain in the lung. That is the residual volume. you will not be able to forcefully expel it out. And this volume is important because if you can expel all the air out, then the lung will collapse, number one. Number two, the blood is always going to the lung, right? It is involuntary. So if you forcefully expel the air out, just think that if you can expel all the air out, then blood will go to the lung and will come back without getting any oxygen. So the pH of blood will suddenly go down. Your body will be acidic. Okay, so that amount of air that you cannot forcefully expel out will remain in the lung still after you forcefully expel the air. That is actually for security. It is preventing the collapse of the lung, number one, and number two, it is making sure that the blood going to the lung is getting some, at least, amount of oxygen. Okay, ensures that the blood doesn't get back without getting oxygen. So residual volume is important for those two reasons. Okay, so now the capacities. I told you the capacities are the addition of two or more volumes. Total lung capacity, total. So if you add all those four volumes, you get the total lung capacity, which is more in male and less is in female because of those two main reasons. One is the strength of the muscles, respiratory muscles, and number two, the size of the lung. Vital capacity, if you add tidal volume and two reserve volumes, inspiratory and expiratory, that gives you that vital capacity. This is also more in male and female, less in female. Inspiratory capacity, if you add the tidal volume and the inspiratory reserve volume, that is the total amount of air you can forcefully intake, including the normal amount. Okay, so that is the inspiratory capacity. And functional residual capacity is the amount of air that remains in the lung after normal expiration, not forceful. After forceful expiration, that's the residual volume. Okay, but after normal expiration, that remains, that is the functional residual capacity. So two are different. Okay, those two. So those are the capacities, and we measure the volumes and capacities to see the ability of your lung to expand and recoil. So that is the lung function test. Now, in certain clinical conditions, the lung may lose the ability to expand enough. In that case, the volumes and capacities will be less, right? So the word compliance we use to indicate the ability of the lung, the elasticity of the lung. Okay, so if the lung tissue gets loses the elasticity, gets fibrous in fibrosis, you can easily think that the elasticity would be less, right? So the volumes and capacities will be less. In pneumonia or bronchitis, the ability will be less. So the amount of air or volume that enters or gets out will be less. Okay, so it is important that we measure the uh, volumes and capacities. So this is the chart nicely showing those volumes and capacities. So you see this is normal 500 milliliter, that means normal tidal volume. Okay, and this y-axis is showing how much air is inside the lung. Okay, inside the lung, remember how much air inside the lung. So when you inspire the air inside the lung, the air amount goes up, like 500 milliliter, right? When you expire, goes down 500 milliliter. So this is the normal tidal volume. Now, after normal inspiration, the inside the lung, the volume is here, right? Normal inspiration. Then, if I ask you to forcefully inspire, you can take a lot more, right? So this is the inspiratory reserve volume. Inspiratory reserve volume, you see here. And if I ask you after normal expiration to forcefully expire, this amount you can forcefully expire. That's the expiratory reserve volume. Okay. And after you forcefully expire the air out as much as you can, still inside the lung, some air will remain, right? We talked about that. That's the residual volume. And here you see the capacities. For example, total lung capacity, you see you add those 4 volumes. So whole, you know, uh, after you add all those 4 volumes, you get the total lung capacity. Here, vital capacity, you add 3, 1, 2, 3. Okay, and get the vital capacity. So those are the volumes and capacities. Dead space. Dead space is the area where no gas exchange occurs. So very simple. Dead space is the area where no gas exchange occurs. No gas exchange occurs. Now, if I ask you, how about your nasal cavity? How about pharynx, larynx, trachea, primary bronchi, and inside the lung? You remember the bronchial tree all the way to terminal bronchial. We talked about that in last class. From the nose to all the way to the terminal bronchial. Uh, all these structures are only for the passage of gas, not for gas exchange. So this whole part is called the anatomical dead space because the structures are built that way. Anatomical dead space because they are not built for gas exchange. So no gas exchange occurs. Okay, that makes sense. Now let's see inside the lung. This is terminal bronchial, and you remember then respiratory bronchial. So this is the respiratory bronchial, and then alveolar duct. You remember 3 structures where the gas exchange occurs, belong to the respiratory zone. So respiratory bronchial, alveolar duct, and then alveoli, right? You remember? Okay. So now, if a blockage occurs here, then what will happen? These alveoli will not get any gas. However, these alveoli will still get gas because these ducts are open. Only this duct got blocked. Okay. So these alveoli will now be termed as alveolar dead space. Dead space. So now you see, we know that alveoli are for gas exchange, so gas should go there. But if due to any blockage, some alveoli don't get the air, then no exchange will occur. That area will be termed as alveolar dead space. So now the alveolar dead space can be created, uh, uh, and you can remove that blockage by medicine or dilating the bronchi, and then it will go back to normal functional alveoli, right? So the alveolar dead space can be changed by exercise, by medicine, right? However, anatomical dead space is fixed, right? Those structures are built for the passage of gas. Now, if you add these two, anatomical dead space plus alveolar dead space, that is called the total dead space in your respiratory system. Okay, total dead space. Exchange of gas in the lung and exchange of gas in the tissue. You must remember the gas exchange in the lung is called the external respiration, and gas exchange in the tissue is called the internal respiration. What happens in external respiration inside the lung? The alveolus. So this is the alveolus, and you know that capillary is on the alveolus. So this is the capillary. Okay, capillary, and you see the alveolar wall and capillary wall, these two are together here, right? And these two structures together is called the respiratory membrane. Respiratory membrane, through which the gas exchange occurs inside the lung. So two walls, right? Alveolar wall, thin alveolar wall, and thin capillary wall. So when the gas exchange occurs, the gas must cross those two walls, the respiratory membrane. Anyway, so blood goes to the lung to get oxygen, right? So from the alveolus, oxygen goes to the blood. We know that, we talked about that. So the pressure of oxygen should be higher inside the alveolus and lower inside the blood. Makes sense? That will move the oxygen. So how much pressure is inside the alveolus? 104 millimeter of mercury. Okay, and inside the blood, when blood enters into the lung, it is only 40 millimeter of mercury. So you see the pressure difference is 64. 104 inside the alveolus and only 40 inside the capillary. Okay, so due to that 64 millimeter of mercury pressure difference, that's a lot, right? The oxygen will move from the alveolus to the blood. So blood will get more and more oxygen. And I told you the carbon dioxide always moves to opposite direction. Okay, so the pressure of carbon dioxide should be higher in the blood and lower in the alveolus. So outside of the alveolus, that means in the blood, the pressure of carbon dioxide is 45 millimeter of mercury. 45 millimeter of mercury in the blood, capillary blood, and inside the alveolus it is only 40. So difference is what? 5. 45 is in the blood and 40 in the alveolus. So due to that 5 millimeter of mercury difference, carbon dioxide will move, and due to 64 millimeter of mercury, oxygen moves. Now why to move the oxygen you need more pressure difference or more pressure than carbon dioxide, much more, right? Because the respiratory membrane, this membrane is less permeable for the oxygen. So to move the oxygen, you need more pressure than the carbon dioxide. Carbon dioxide is 20 times more permeable than the oxygen in the respiratory membrane. So that is the external respiration. So blood gets oxygen and gets out, go to the heart. And from the heart, the blood is sent to the tissue. So now let's see the tissue. These are the cells in the tissue. Okay, so this is the tissue. and the gas exchange occurs in the tissue. That's the internal respiration. Okay, and this is the capillary, brings oxygen to deliver to the tissue. So oxygen will go from the blood capillary to the tissue. So the pressure of oxygen must be higher here and lower here. So here the pressure is 100 millimeter of mercury, and here is only 40 millimeter of mercury. So the difference is about 60 millimeter of mercury. And carbon dioxide always moves to opposite direction from the tissue to the blood, because we know that tissue produces carbon dioxide when by metabolism. So carbon dioxide will move from the tissue to the blood, and the pressure of carbon dioxide in the tissue is 45, and the pressure of carbon dioxide in the blood is 40. So only 5 millimeter pressure difference will move the carbon dioxide from the tissue to the blood. So blood will become deoxygenated and will go back to the heart, the deoxygenated blood, and that is the internal respiration. Okay, so internal respiration in the what happens in the tissue, external respiration what happens in the alveolus of the lung. So now if you go over these slides, you see the pressure differences I mentioned here. Also you see, so make sure you go over, you see in the lung, oxygen in the alveolus is 104, and oxygen in the blood is only 40. So the difference is 64. So that is one thing. And in the tissue, you see the pressure of carbon dioxide inside the tissue is 45, and in the blood is 40. So the difference is 5. And here the oxygen pressure is 100 in the blood, and oxygen pressure in the tissue is 40. So 40 here in the oxygen in the tissue, and oxygen in the blood is 100. So 60 millimeter of mercury pressure will give the oxygen to the tissue here. Ventilation perfusion coupling is important. What is that? Your heart should send the blood to the lung when you inhale the air. Just think that you are inhaling the air, taking the air from outside to inside, taking the oxygen from outside to inside, and your heart is sending the blood to the lung at the same time. That is the coupling, right? So that is efficient. Now, if your heart sends the blood to the lung, perfusion occurs. Perfusion means flow of the blood in the lung. So if perfusion occurs, or flow of the blood occurs in the lung, when you are expelling the air, or you have already expelled the air out, that flow of blood is not very helpful, because the air you have expelled out from the lung. So those two things, the perfusion or flow of the blood in the lung and inhalation, exhalation, should be coupled to make sure that blood gets enough oxygen. Transport of the gases. Oxygen is transported mostly by the hemoglobin, binding with the hemoglobin. 98.5% of oxygen, volume of oxygen, is transported by the hemoglobin. Only 1.5% get dissolved in the plasma. Plasma is the liquid part of the blood. So in that liquid, 1.5% volume of oxygen is dissolved and transported. So mostly by the hemoglobin, red blood cells. Now, how much oxygen will bind with the hemoglobin, that is determined by 4 factors. How much the pressure of oxygen is there, what's the body temperature, what's the pH of the blood, and what's the pressure of carbon dioxide. this is very simple. You just think that if the pressure of oxygen is more, the binding will be more. That is called saturation. Binding is called oxygen binding with hemoglobin is called saturation. So more oxygen available, more pressure of oxygen, that means more saturation. Temperature. If the temperature increases, the saturation will be less. The binding will be less. Okay, saturation will be less. If pH is low, the saturation will be less. Okay, less saturation. If carbon dioxide pressure is high, then the saturation will be less. Okay, so uh, only when the pressure of carbon dioxide is high, and uh, in that case the saturation will be low. If the temperature of the body is high, saturation will be less. If the pH is low, saturation will be less, and if the carbon dioxide pressure is high, saturation will be less. Okay, so normal saturation curve is like this, and if the curve moves this way, that means saturation is less. If the curve moves that way, left, that is more saturation. So that is called saturation curve. So less, because this way we plot the saturation. Okay, and so if it moves this way, the curve, that means more saturation, faster. Moves that way, slower saturation. Okay, so here this is normal saturation curve. Okay, and you see that if the temperature increases, this is normal body temperature, right? This one. So normal saturation curve. If the temperature increases, saturation is less. If the temperature decreases, saturation more. So the curve shifts leftwards. Here you see the pressure of carbon dioxide. If the carbon dioxide pressure is high, saturation will be less. Decrease carbon dioxide pressure, saturation will be more. Okay. Now, how blood transports carbon dioxide? Carbon dioxide is mostly transported as bicarbonate, not by hemoglobin. Okay, as bicarbonate. About 70% volume of carbon dioxide is transported as bicarbonate. 20% by the hemoglobin, and that bind after the hemoglobin gets attached to the carbon dioxide, joined with the carbon dioxide, that hemoglobin is called carbamino hemoglobin, and 7 to 10% dissolved in the plasma. Okay, now how the blood transports carbon dioxide as bicarbonate. This is your blood. Okay, uh, blood is here, and carbon dioxide enters into the blood, and blood has a lot of water, right? So carbon dioxide will react with water and will produce H2CO3 carbonic acid, and it will quickly split into hydrogen and bicarbonate. So now, where is this carbon dioxide? If I find the carbon dioxide is here, right, inside this. So now this reaction is helped by an enzyme called carbonic anhydrase, or Ca. Very fast the reaction will occur, and when the bicarbonate needs to release the carbon dioxide, just opposite reaction will occur, but again very fast, quick. So bicarbonate will produce carbonic acid, and carbonic acid will release the carbon dioxide and water. Okay, so that's how 70% carbon dioxide is carried by the blood as bicarbonate. So here you see 70%, the amount is shown by thick line. So carbon dioxide by blue, arrow. So you see here, most of the carbon dioxide, that means 70%, binding with water very fast and producing carbonic acid, and it splits into bicarbonate and hydrogen. Okay, and carbonic anhydrase is the enzyme, and then about 20% by binding with hemoglobin, carbamino hemoglobin. Okay, and a small amount dissolved in plasma, 7 to 10%. Okay, and you see here just opposite reactions occur when bicarbonate needs to release the carbon dioxide in the lung. So this is in the tissue, right? The blood is getting carbon dioxide and giving oxygen, the red line, to the tissue. And now you see oxygen is 98.5% is transported by the hemoglobin. So that is as oxyhemoglobin, and only 1.5% dissolved in plasma. Okay. Control of breathing in the respiratory center. You have respiratory centers in the brainstem. You must remember the pons. This is the pons, and this is the medulla oblongata. Okay, so in the pons you have a respiratory center that is called the pontine respiratory center, and in the medulla you have group of respiratory centers, ventral and dorsal groups. Okay, so this is ventral, this is dorsal, and this is pontine. So those are three centers. Now what happens, the dorsal respiratory group, this one receives, so these neurons of dorsal respiratory group receive signal from the wall of the chest wall, pleura, the covering of the lung, as well as the lung tissue. Okay, so what kind of signal? The signal is in the chest wall, in the pleura, and in the lung tissue. Everywhere you have stretch receptors. Stretch receptors. So these receptors uh, get activated when the lung or chest wall or pleura, uh, the pressure increases. That's why called stretch receptors. When the lung expands, you know that the pressure increases in the lung, right? Also in the pleura, the covering of the lung, and the chest wall. So that increased pressure will activate these receptors, and the receptors will send signal to the dorsal respiratory group of neurons. So these neurons will get the signal how much expansion has occurred. Okay, and when the lung expands enough, the dorsal center will send signal to the ventral, and ventral will do what? Will send the signal, you see, output signal to the intercostal muscles and diaphragm, and will tell them to stop because lung has expanded enough. So these muscles will relax. Okay, and that will end the inhalation. So again, when you inhale, the lung expands, so the receptors are activated. These receptors send signal to the dorsal. Dorsal is receiving signal from the receptors. Okay, from the receptors, and monitoring how much expansion has occurred, and will send signal to the ventral, and ventral will send signal to the muscles to stop further inhalation. If that doesn't happen, then the your lung will continue to expand. But that doesn't happen, right? It expands, then it stops by itself. Voluntarily, involuntarily, you don't do that. Autonomic, right? It is happening 24 hours. Lung is expanding up to a certain limit and getting stopped and then recoiling. So these two centers are doing that. And pontine respiratory center is just doing the fine adjustment. If any adjustment is needed, if any irregularity in the breathing pattern, then the pontine will take will fix that. So fine, in one word we can say fine adjustment. Okay. So again, dorsal receives the signal from the receptors and sends signal to the ventral. Ventral sends signal to the muscles to stop. And so here a reflex that is called Herring-Brewer reflex. That is the reflex when your lung starts to expand, the stretch receptors are activated, right? I told you they are present everywhere in the wall of the lung, in the lung tissue, in the bronchi, in the pleura, in the chest wall, and they will be activated by pressure, the expansion of the lung, and then uh, after a certain time, the lung will stop. So that is the Herring-Brewer reflex, and that is happening 24 hours, right? Now, if that reflex doesn't work, then the lung will keep expanding, and that can cause the destruction of the alveoli. Okay, the factors that increases the and or decreases the respiratory rate and depth. So, what are the factors increase the respiratory rate? One is your cerebral cortex. You have voluntary breathing centers. If I ask you to increase the rate voluntarily, you can do that, right? If I ask you to slow down your lung, you can do that. Your respiration, if I ask you to stop, you can do that, right? So in the cerebral cortex, you have voluntary center, and that you can use to voluntarily control the breathing. So that could be positive or negative. That means you can increase or decrease. It's up to you. Then in the hypothalamus, you have the pain, emotional, you know, uh, area that can change the breathing. In pain, if you get strong pain, then the breathing pattern changes. The emotional state, in high emotional state, the breathing changes. Um, chemoreceptors. There are receptors in the wall of the aortic arch and the division of the carotid artery. So this is common carotid artery and this is aortic arch. In the wall, you have the receptors called chemoreceptors. They are activated by the carbon dioxide and oxygen. So if oxygen pressure goes down, the carbon dioxide amount increases, these receptors are activated and they send signal to the respiratory centers. You remember in the pons and medulla oblongata, you have the respiratory centers will be activated and that will increase the rate of respiration because the carbon dioxide is more, oxygen is less, so you need to breathe more, right? So to expel the carbon dioxide out and get more oxygen. uh, Stretch receptors, I already talked about that. Herring-Brewer reflex will inhibit further expansion of the lung. Irritant, if something dust or something or gas or gasoline smell enters into the respiratory system, then that will stop the breathing, right? And you will probably sneeze after that. So negative, stopping or inhibiting. exercise will increase, we know that, the breathing. So those are the factors. Okay, now the last thing, I'll talk about few clinical conditions in next. So asthma is the clinical condition that is called allergic reaction. So asthma is an allergic reaction in which the constriction of the bronchoconstriction occurs. Okay, so the bronchioles, bronchial tree, you remember that, the small bronchioles uh, constrict, so the air will not be able to pass through the bronchioles. Okay, so the person will have difficulty in inhaling or exhaling the air. Now, what causes asthma? Since it is allergic reaction can vary person to person. Someone uh, could be allergic to temperature, like cold. Someone could be allergic to mold, right? Someone could be allergic to food, like peanut or certain food, or could be dust, right? Uh, or certain chemicals. So that pollen. So allergic reaction can occur due to a number of things or factors. However, the result is when the person will get allergic reaction in the body, chemicals will be released. The one is called histamine. Okay, so histamine will cause mainly the bronchoconstriction, and the person will have difficulty in inhaling or exhaling the air. In that case, you will take the inhaler that will cause the bronchodilation. So you'll take what? Bronchodilator. So the person will have, the breathing back normal. Pleuritis, also called pleurisy. I mentioned that same thing. The inflammation of the pleura, that means covering. So two layers will rub each other, friction and sharp pain will be felt during breathing. So inflammation of the pleura. Okay, it could be bacterial, viral infection, or chemicals can also cause inflammation. Emphysema, the destruction of the alveolar wall. I explained this one before. So these are the alveoli, normal intact alveoli. Now if the alveolar wall is destroyed, then it will look like this. Make sense? So the total surface area will decrease. So gas exchange surface area will significantly be less. So the person will have hypoxia, less oxygen in the tissue, and problem will feel extremely tired, shortness of breathing. Tuberculosis. Tuberculosis is a bacterial infection in the lung tissue. So that bacteria called tuberculin bacteria, that bacteria causes infection, and this happens. When this happens, the person will have cough, sputum, and sometimes if it's not treated, that infected lung, bacterial infected lung will produce blood, and that will come out with the cough. Okay, so this bacteria loves the uh, lung tissue, but the tuberculosis can also occur in other tissues. For example, in the uh, bone, we say osteotuberculosis. Okay, so that bacteria can also infect other tissues, but as I told you, this bacteria uh, prefers the lung tissue. That's why it infects the lung most of the cases, and that is called pulmonary tuberculosis. When it infects the lung, that is called pulmonary tuberculosis. You hear this a lot. Tuberculosis. Okay, and the name of this bacteria is Mycobacterium tuberculosis. Okay, so this bacteria uh, prefers the lung tissue and cause the pulmonary tuberculosis. Pneumonia, I talked about this. If the alveolar wall is infected, the lung tissue, then the alveoli will get filled with fluid or sometimes pus. Um, hypoxia, lack of oxygen uh, in the tissue, lower oxygen in the tissue of the body. Okay, so that is hypoxia. However, if the oxygen is low in the blood, remember that is not hypoxia, that is called anemia, right? You have learned about this. So lack of oxygen in the tissue. Hypoxia can be physiological hypoxia, which is not a disease. If you go on the top of the mountain, your air oxygen pressure in the air is less, so in that case you will get hypoxia, but when you come back, it will get back to normal. So that is one. Another could be due to anemia or other blood disorders. Apnea, A means absence of breathing. So temporary stoppage or cessation of uh, uh, breathing. Okay, so stoppage of breathing. However, temporary, right? If it is permanent, that's death. Hypercapnia, if the carbon dioxide in the blood increases, that is called hypercapnia. So hypercapnia will cause tachypnea, increase the rate of respiration. You remember tachycardia, first heartbeat or heart rate. So tachy means first, tachypnea means increased respiratory rate, the number. Dyspnea, any kind of disorder of breathing is called dyspnea. Okay, of breathing. So those are some clinical conditions related to the lung. Another one is bronchitis. Bronchitis, uh, very commonly heard, right? And it could be acute. It will appear suddenly and go away in few days or couple of weeks. That is acute. And chronic will stay for years or rest of the life. So chronic bronchitis. Okay. What happens in bronchitis? This is your bronchial. Okay. And if you see inside the bronchial, thick mucus form, uh, clog So many narrow bronchioles will get clogged by thick mucus, and also because of the secretion of thick mucus, the passages will be narrower. Okay, so this is not bronchoconstriction, not asthma. This is bronchitis in which the uh, mucus that blocks the narrow bronchioles. And chronic bronchitis can occur due to smoking. That is the most common cause. Okay, smoking is the most common cause. However, any kind of infection or chemical can cause that.